As many of you know, primary prevention ICDs are implanted under what is predominantly a 1A indication in both the US and European guidelines for patients who have either ischemic or non-ischemic cardiomyopathy with an ejection fraction under 35% who require appropriate guideline-driven medical therapy. So let's start with Dr. Al-Khatib, who's going to start with a discussion of the clinical trials that led to these guidelines, and then a discussion of are those trials still relevant today? Thank you for joining us, Sana.
Of course, my pleasure. Thank you. So many of us are aware of the strong evidence supporting the role of the primary prevention and secondary prevention ICD. And this evidence came from randomized clinical trials shown here. Some of these trials, like the MADE-IT1, MADE-IT2, MUST, and SWEDEHF, looked at primary prevention ICDs. Definite was a primary prevention ICD as well. And we have secondary prevention ICD trials, including AVID, CASH, and SIDS. And we know that based on the strong data from these trials, that the following patient groups benefit from ICDs. First, survivors of cardiac arrest attributable to ventricular tachycardia or ventricular fibrillation. Patients who have sustained ventricular tachycardia not in the setting of a reversible cause. And of course, a large population of patients with a significant systolic dysfunction, EF of less than or equal to 35%, as was mentioned by Rob, due to ischemic or non-ischemic cardiomyopathy despite optimal medical therapy. And so with that evidence in mind, it is important to note that some have questioned the relevance of the ICD in today's clinical practice. And the following 3 points that you see here before you have been put forward in terms of why people are questioning the role of the ICD today. Point number 1 is that these landmark trials, while they were really well designed and conducted, they were completed more than 15 years ago. So many people are asking whether the results of those important trials still apply to the average patient that we see in clinical practice today. Point number 2, which is a very good one, is that medical therapy for heart failure has evolved drastically. And that is indeed true. If you look at the different medications that are available to clinicians today for the treatment of heart failure, including beta blockers, ACE inhibitors, ARBs, ARNI, aldosterone antagonists, all of which have been shown to improve survival and reduce the risk of sudden cardiac death, I think it is important to ask whether the ICD could offer a survival benefit beyond the benefit that one derives from these medications. And third, the Danish trial, which was published in September of 2016 and enrolled patients with non-ischemic cardiomyopathy, randomizing them to an ICD versus no ICD, was neutral. So it is really important for us to reflect on all these 3 endpoints and try to really understand what's going on there. So with this, I'd like to turn it over to my colleague, Gianluigi, to talk about some really exciting data that came out last year.
Thank you, Sana. At the ESC Congress 2019, indeed, 2 studies assessing the association between ICD use for primary prevention of sudden cardiac death and mortality have been presented. One study has been presented by our group at the Karolinska Institute and was based on the Swedish Heart Failure Registry data. The second study was a non-randomized prospective study and was called EU-CIRT ICD study. The Swedish Heart Failure analysis enrolled patients between 2000 and 2016, whereas the EU-CIRT study considered patients enrolled between 2014 and 2018. Both studies had as inclusion criteria recommendation for ICD for primary prevention of sudden cardiac death according to the ESC 2016 heart failure guidelines. In the Swedish Heart Failure Registry analysis, we assessed prevalent use of ICD, whereas in the EU CERT ICD study, they assessed the incident use of ICD, meaning that patients implanted with an ICD for primary prevention of sudden cardiac death at the baseline were compared with patients who did have a recommendation for ICD for primary prevention of sudden cardiac death, but who didn't get the device because the patient didn't want to get the device, or the physician didn't suggest the device in these patients, or because the healthcare system didn't provide enough support to reimburse the device in that setting. And both studies had as outcome mortality, and since they were observational study, very sophisticated statistical methods were used for adjusting for potential confounders. This slide reports the baseline characteristics in both studies. As you can see, these studies were run in real-world heart failure population. In the Swedish Heart Failure Registry Court, median age was 70 years, whereas in the EU CERT ICD, it was a little bit lower, it was 62 years. In both courts, patients receiving ICD were younger, more likely males, more likely with history of ischemic heart disease and with atrial fibrillation. And very important, in both studies, there was like a good use of heart failure guidelines recommended therapies. And the first finding of this study that you can see in this slide is that in the Swedish Heart Failure Registry analysis, only 10% of patients with recommendation for ICD for sudden cardiac death prevention really received a device. Let's go on with the results of the first of these two studies, the analysis from the Swedish Heart Failure Registry. The result was that ICD use was associated with a 27% reduction in risk of all-cause mortality at 1 year. And there was also a 12% reduction in all-cause mortality risk at 5 years. And we did perform in this analysis subgroup. We did assess several subgroups to check if there was any difference across subgroups for the association between ICD use and mortality. And we could not see any difference across several subgroups explained, which were ischemic heart disease, sex, age, contemporary versus less contemporary care, CRT, NIA class, and ejection fraction. Let's go on with the second study. In the second study, the EU CERT ICD study, it was shown that ICD reduced by 27% the risk of all-cause mortality at 4.8 years follow-up. And there was also a 83% reduction in risk of sudden cardiac death. Subgroup analysis was performed in this study as well, and it was shown that the association between ICD use and mortality was consistent across all the subgroup identified. And there was like a signal for a greater reduction in risk associated with ICD use in younger patients and in patients without history of diabetes.
Thank you both for that excellent review of the prior trials and the contemporary ones. With that, I want to turn it over to you, Michael, to kind of take on those next two topics about how medical therapy has evolved and some discussion of the Danish trial and how we put that into context.
Yeah, thanks, Rob. Certainly, in the last 15 years, there have been significant advances in medical therapy. Certainly there's a greater use of aldosterone antagonists as we appreciate how valuable they are, even though they're older drugs. And I think most importantly has been the ARNIs, which is a new class of drugs, actually a combination drug. But the Paradigm HF study showed a 20% reduction in cardiovascular mortality compared to traditional ACE inhibitor use. What was surprising in several ways was that despite a heart failure population, only 15% of these patients had defibrillators, which will be a topic we'll come back to, I think, repeatedly over this short period of time that we have together. Of those patients who did get a defibrillator, however, there was a 24% reduction in mortality for those patients who had the defibrillator compared to those who did not have a defibrillator in that group. So again, suggests that even with contemporary medication, that there certainly is still a role and a benefit of defibrillators. However, what has really created much controversy and discussion has been the Danish study, which was a large, well-performed and well-executed study of over 1,000 patients who were randomized in an unusual way for these types of studies. They were randomized to an ICD or usual clinical care. What turned out to be usual clinical care in a majority of patients was still a device implant, but it turned out to be a CRT pacemaker. So the Danish study is very, very different in terms of the cohort that was studied compared to those that have been in any of the previous studies or in our clinical practice. So almost 60% of the patients randomized in this study received a CRT device, either CRT pacemaker or CRT ICD. And the mean QRS duration of this population was about 145 milliseconds. Again, much higher than what we see in traditional registries or randomized trials of ICDs, which is closer to 120 milliseconds. So certainly raises the issue of whether there was some selection bias in terms of the types of patients who were in that study, and a majority of them received a device protecting them from bradycardia as well as treating their heart failure. Patients, it should be noted on a Danish study, it's probably the best study ever performed in terms of guideline-directed medical therapy. Of all the device studies we've done, 97% were on an ACE or an ARB in this study, 85% on beta blockers, 97%, 92% on beta blockers, and a majority were on aldosterone antagonists. So very, very high penetration of appropriate medical therapy in that group of patients. What we do need to note, which is very unusual, as shown on this slide, was an extremely low risk of sudden cardiac death in the Danish study. This is a slide showing all the randomized studies in heart failure of drugs or devices and looking at the control groups in terms of devices. And what we can see is in the Danish study, the overall sudden cardiac death rate was only about 1.5% per year. And that is strikingly lower than any other study that was performed. It's extremely unusual, not terribly well explained at this point yet, but clearly indicates that this may have been an underpowered study if there's such a low risk of sudden cardiac death in this population for whatever reason it was, that there's really no opportunity to really show much of a benefit of ICDs, which is what came out of this study.
Michael, can I actually ask you a question about that? As you know, Danish was the only randomized clinical trial of ICDs that required that patients have an elevated pro-BNP at baseline. And if you look actually at the patients who were enrolled in the trial, the median pro-BNP was well above 1,000. So clearly those patients had heart failure. Do you think that that may have biased the results toward a higher risk of heart failure related death than sudden death? What are your thoughts on that?
I think it's a great point, and certainly a possibility that because the population was enriched in severe heart failure as reflected by the high incidence of CRT used and the high incidence of BNP, that there may have been higher proportion of heart failure deaths in that population. So certainly that may have been one of the contributors to it. But when we dig a little bit deeper into the study, there was a pre-specified subgroup analysis that was looking at patients based on age. And what we can see that despite the high levels of BNP, despite the high levels of CRT pacemakers used in the study, patients under the age of 70 still had a benefit of ICDs, as shown on this slide here. So there are important subgroups of patients. And again, not surprising, as patients age, we see a higher incidence of competing morbidities and comorbidities that can lead to mortality, harder to show benefits of defibrillators in that group of patients. And it's important to, again, reflect on the CRTP population in there, because we know that patients who remodel have a much lower incidence of overall mortality. Shown here is a study that we published based on the reverse study, showing that those patients with significant remodeling had a markedly, almost 70% lower total mortality over a long period of time. And DANISH enrolled only non-ischemic cardiomyopathies, which are more likely to remodel, and then with women and a high incidence of left bundle branch block. Again, not surprising that the incidence may have been lower in that group of patients. And I just want to reflect finally on a new observational study. And while the study's new, this is the same Danish population we've been talking to. It was a sub-study of patients who received MRIs. And there's been a lot of discussion about whether gadolinium enhancement, late gadolinium enhancement as a marker of scar, is potentially a marker of high-risk patients who may benefit from defibrillators. And certainly it's a group that's been shown to have a higher mortality. And in the Danish study, it was shown that in fact this was a marker of higher total mortality, but it did not predict those who would benefit from an ICD. So possibly this is not necessarily a subgroup more enhanced in terms of ICD benefit.
So Mike, great. Thanks for that great overview of those, of the second and third issue going on. Zana, your group has done a lot of more recent work using existing registries and re-looking at trials. Can you review some of that for us as well?
Yeah, of course, I would be happy to. So the data that were presented by Gianluigi were really interesting and very important data in my view. But some may actually look at the data and say, well, those were done in Europe. Have we done anything similar to that in the US? And indeed, our group did publish several analyses. We are showing two of these here. The top one is focused on patients enrolled in the MADE-2 and the SWEDEHF trial. We actually used patient-level data from those trials. And then we compared patients who were like MADE-2 and like SWEDEHF patients who were receiving ICDs in clinical practice. We found that the patients who got an ICD in clinical practice had a similar survival to the patients who received an ICD in MADE-2 and SWEDEHF. And both of these groups had a better survival than patients who were randomized to receive medical therapy only in those trials. And then we followed that with another important analysis focusing on a subgroup of patients with an ejection fraction of 30 to 35%. And the question was, can we find a signal there in terms of a survival benefit associated with the ICD? And indeed we did. We actually found that patients with an EF between 30 and 35% who had an ICD had a significantly better 3-year survival than patients who did not have an ICD. And so to go back to those 3 points that we started the presentation with, in terms of the evidence from those pivotal randomized clinical trials of ICD might be dated, we actually have shown you data both from Europe and the US showing that actually ICDs are still associated with improved survival in today's clinical practice. When we talked about the improvement in medical therapy that we have seen, without a doubt, medical therapy for heart failure patients has improved. But despite that improvement, we still see that the ICD offers survival benefit to patients with heart failure. And finally, Michael gave us a really nice overview of the Danish trial. And it's really important to understand the nuances of that trial to interpret its results accurately.